All right, good morning, everybody, and welcome to the EQIP subgroup meeting for the Maryland Health Services Cost Review Commission. Um, Today, we're going to give some updates as we're in the middle of enrollment. And I guess the first update, if we want to go ahead and go to the next slide, Angelico. I'm sorry. Anyway, is the QPP issue. Next slide. So, as you know, we've been working very hard as a team trying to resolve the QPP issue. We were hoping to have a finalized update for you today, but we're not going to have that. But just on the good news front for everybody, MedCai convened a meeting with CMMI and the HSCRC, and it went very well. We are hoping that we will have a detailed final resolution with a timeline that will be favorable to everybody by the next EQIP meeting in 2 months, which will be in August. So both sides are trying to come up with a solution to fix the problem for the practitioners. There are just some technical constraints on both sides on how it can be resolved. So I will say that that a day has not gone by that Krista and Will from HSCRC and Kim and everybody from Chris, Megan have been very, very focused on this issue, and everybody at MedCai has as well. So we've all been trying to work together to figure out how to get there. And like I said, I think we're making real progress, and I'm hoping that we'll have a timeline with a real solution at the next meeting in August. Any questions on the QPP thing? All right. I'm going to go ahead and turn it over to Kim to drive the train for a bit and take over from there. It's all yours, Kim.
Awesome. Okay, Angelica, Yep, perfect. All right. So as Jean said, we are currently in open enrollment. Go ahead to the next slide. And the portal is already open. So if you have not already started your application, please go ahead and log into the portal, to the portal and get your application started. If you need a walkthrough on the portal, because we know there's been a bunch of changes, we do have a video that walks you through it, step by step, and that video is linked here. You can also find that video on our website. You will also be provided with the recording from today's subgroup meeting as well as the slide deck, so you'll have access to that link. And our enrollment cycle will close on August 21st. Next slide. And this is basically just a timeline. We're, reiterating exactly what I just said. Enrollment's open. The pre-enrollment form, which we'll get into a little bit later, the deadline for that is August 7th. And that's just basically to get access if you don't already have access to the portal. And then again, enrollment closes on the 21st of August. Next slide. All right, so for returning entities, all returning entities must reapply every year, okay? This lets us know that you are interested and that you actually do want to participate. Applications are not considered complete until the submit button, the arrow that you see down at the on the picture there, is selected. If an application is not submitted, we will then assume that your entity does not wish to participate in the upcoming performance year. Basically, all you do is go into the portal for all returning entities. Your prior year application pre-populates. You run through your information in there, make sure that, nothing has changed, or you change and make any additions that you need and want to for next year's application or next year's performance year. And then you hit the submit button. Group just asked a question. Does renaming the entity? Yes, renaming the entity will change the entity ID. Yes. Okay. Optional for everyone is that if you wish to receive like baseline data for the providers that you want to participate in your entity that year, you can request that information. Use the template that we have linked here in the slide. And all we really need is the individual MPI, care partner MPI numbers, as well as the care partner name. Send that to the EQIP inbox and we'll run the data for you and send it back to you. Next slide. For brand new entities. And for any new entity or an existing participant that wants to establish a new entity, the first step would be to submit what we're now calling the pre-enrollment form. This form is basically just information that we use to get your people, the people that are going to be putting in the application and looking at the data, access to the actual portal. This process has significantly cut down for us compared to years prior in getting people access. And as you know, there's a lot more steps now that we have to take since the EQIP portal is now within the CRISP portal. So if you are brand new or if you are starting a new entity, we would appreciate it that you fill out this form. This gives us everything we need to get you your access. This form needs to be submitted by August 7th because it takes up to about 2 weeks to get the accesses needed. And anything after August 7th, we will run the risk of you not getting the access in time to get your application submitted. So, as a reminder here, eligibility for episodes to participate, again, with the MPI summary file, you can also request the MPI summary file, which is a baseline data that gives you information on the care partners, whether or not they've touched a claim within the baseline year, as well as which episodes that you are eligible for. A minimum of 11 episodes must be granted or must have been, I'm sorry, a minimum of 11 episodes or 11 touches of the episodes must be touched in the baseline year in order for you to qualify as being able to participate in that episode. Hoping I'm making this sound clear. And then you must have a minimum of 50 episodes in total, right? Not just like if you're participating in 2 different episodes, you would need a minimum of 50 episodes to proceed and to participate in EQIP. Any questions on that? Because I know I just bungled that all up. So I want to make sure that, go ahead, Madeline.
Sure, thanks, Kim. No, I don't think you bungled that up. We actually have a question about the new rules around mutually exclusive EQIP episodes.
I'm getting to that later. I promise you.
Okay.
All of that.
Okay.
Yep.
Yeah,
Okay.
because that's really snagging and kind of holding up our ability to assess baseline eligibility and what's going to be available for enrollment, especially given we've got a shorter period here. So,
Yes.
Great.
Okay. Again, please don't wait until the last minute to apply. Get in there now and get your applications done. Next slide. For new and returning entities, again, this is also another new item in the portal. We are asking each entity to select the submit button when you are completed with your application. And the reason behind this is that this just assures us for certain that you are absolutely interested in participating in that next program year. So when you are filling out your application, please do not forget to hit that submit button. Otherwise, we're going to assume that your intention is not to participate in program year 6. Okay. I think that's it. Again, the deadline is August 21st. Next slide. All right. Enrollment updates. So we have some stats that we'd like to share. So far, we have 50 entities that have gone in and started applications. We have one application that was actually submitted, and then now as someone's going back in and revising some things. That's also something else that I want you all to know. Just because you hit the submit button doesn't mean that that's it, that's the end, you can't go back in. You absolutely can go back in and make changes. Just make sure that you hit the submit button or the save button every single time when you're done and have finished any revisions, okay? We have 5 entities that have actually completed the application and hit the submit button. And so far, as of now, we have had 20 new entities that have applied for access to the actual enrollment portal. So we have new entities that are going to be participating with us in program year 6. And then we have 149 entities that are existing for this program year 5 that have not yet started their application. So again, I really want to stress, please don't wait until the last minute. Anything can happen, as you guys have seen, and we just don't want you to miss out on an opportunity. Okay, so please get in there and get your applications in. Next slide. Episodes. Okay, so again, we are currently in the enrollment period. And after the enrollment period closes and everything gets settled down and we get everything submitted to CMS, we will then begin talking to the entities about potential episodes for program year 8. So be on the lookout for that. But right now we are only focusing on enrollment right now. So next slide. We added 23 new episodes for program year 6. So that puts us up to about, I think it's 144 episodes in total that you all could potentially participate in. The PY6 playbook has been finalized. It's linked here on the slide. You can also find it on our EQIP website. Next slide. All right, now to Maddie's question. Okay. So we have some mutually exclusive episodes. And so the reason behind this is as we continue to expand the EQIP portfolio, right? Like we've gone from like 50 episodes to now 144 episodes. So the more we expand, the more that we are identifying areas where episodes are measuring essentially the same patients with the same care, okay? So to avoid creating overlapping accountability, certain episodes are now considered mutually exclusive. And the basic idea is that if 2 episodes are evaluating substantially the same population and services, participants must choose one or the other rather than enrolling in both. And again, this is based on the data that we're getting in, okay? This helps ensure that the same care is not measured twice, and that our incentive opportunities are aligned with single episode structure. On this slide, we give an example of the AMI and PCI, which you all knew about last year. You can only participate in either AMI or PCI, not both. There are now orthopedic PACES episodes that now overlap with MSK episodes. So if the 2 episodes are designed as designated as mutually exclusive, you will need to select whichever episode aligns best with your organization's clinical focus and participation goals. Okay, next slide. Same thing here with ED episodes. So MSK and ED, remember, are non-PACES episodes. So these are non-PACES definitions, and that is potentially and exclusively why we are having these overlapping issues, okay? So for ED episodes, if you are participating in, say, ED UTI, you cannot participate in the PACES UTI because then you're basically, it's going to end up being the same. We're going to have duplications here. So we can't do that. It's like a simple rule. I know Maddie, that you're saying that it's kind of messing you up a little bit, and I do understand that, but essentially, if you are choosing, say, orthopedics, right, and say you're doing low back pain, you're going to get your MSK in that low back pain as well. Those claims will hit in your low back pain. Go ahead, Maddie.
Yeah, I think the logic makes sense. I think that the timing here and the availability of detail is where we're really struggling, Kim. We don't know which of these episodes, like we don't have that comprehensive view in. And then the portal opening about a week later, then that August 6th date or the July 6th date that is in the slides, right? We're kind of looking at our baselines now and saying, well, are these, are we going to select wrong? Are we going to move physicians wrong? And is it going to be too late? And we don't have a lot of time to do that maneuvering. And so I think there are two potential solutions. One, if a crosswalk could be made available of where episodes are overlapping, so we know when we're going to hit these sort of landmines and what all is being included, that would be extraordinarily helpful as we only have a couple weeks left here to finish our enrollment. And then if there's any flexibility on Chris' side, because we did wait for the portal to open a bit longer to keep the portal open for enrollment, because there is this change to episode volume eligibility now. I just think it would be helpful. There's so many entities. We as an organization do a good number as well. We do also move physicians around entities to make sure that volumes, but then also operational plans make the most sense. And right now our view into that is pretty limited and changed a little at the 11th hour for us. So those would be my two requests. If we could get some detail on these mutually exclusive episodes, and then also potentially see some movement in that final deadline for enrollment.
Well, definitely we'll take all of this under advisement. Absolutely, we can work on getting a crosswalk put together. And thank you for that feedback. Appreciate that. We do have a few questions. Let's see. Regarding the new entity submissions, is it safe to say if we submit the new entity submission on August 7th, we would get the approval turnaround on the 21st? No. So the reason why the deadline for that pre-enrollment form is August 7th is so that you're not getting the access on the 21st and then have to scramble really quickly. I'm trying to provide enough cushion in there to give you all enough time to get the access and then get in and make your application. I hope that answers your question, Matt.
It did. We have a lot of entities too, so we're trying to debate on if we want to add an additional one for our women's health, but I want to be able to. So if we were to do the submission on the 7th, what is the expected turnaround time for decisions on like entity approvals or rejections?
So we're not approving or rejecting any entity during that time frame. The only thing that's happening on August 7th, as far as the pre-enrollment form for August 7th is it's giving us the information we need so that we can create access for whomever it is that's going to be putting in the application for that entity and needing access into the actual portal for that entity. Does that make sense?
It does. I just do you know what the turnaround time then would be on giving?
Again, it could potentially take up to 2 weeks. It hasn't been taking that long, thankfully. But as we've seen in the past, the closer we get to the deadline, the more everybody starts piling in. And so the more people that come in at the last minute, it can cause a backlog. So 2 weeks is like the max typically. And so that's why I put the deadline at August 7th. That way it gives everybody enough cushion time that we can get the access taken care of so you can get in and do what you need to do.
Yeah, thank you. That helps a lot because I don't want to tell my team per se, hey, you guys have until August 7th to make a decision. I'd rather bump that up a little bit earlier So that way, when access is granted, let's just say a few days before the 21st, then we
Right.
can go in and add what we need to add in, per se.
Right.
So I appreciate it.
Sure, no problem.
Can I make a suggestion from a practical point of view? If
Sure.
anybody is thinking about creating a new entity and it's a possibility, why don't you submit and get set up? And you can always not move forward with it. I just would suggest that would be the prudent way to move forward. Because what has happened in past years, and I think this is what our 6th year doing this or something,
Yeah.
we've had situations at the end where we're trying to figure stuff out and it's complicated and mixed up. So I would just suggest if you're in a position like the last person who just spoke, where I'm thinking about doing it, just submit it. You can always take that doctor that you submitted as the lead care partner and make them a participant in one of your other entities. But let's just go ahead and get them in so we can get them set up and we can start assigning them equip numbers in the system, and you can decide if you want to use them later on.
100% agree with that, and I appreciate it.
Sure. Okay. Stephen, did I answer your question about the mutually exclusive episode logic?
I don't think so. I mean, so the Paces Business Guide, as I recall reading through all the episode construction, I mean, there's a pretty well documented process for how a service gets assigned to an episode, and there's lots of logic in there about how when there is overlapping episodes, what the hierarchy for how we resolve that. So I mean, is there anything? What are we accomplishing with the mutually exclusive designation that isn't already really spelled out in the episode construction?
Is there anybody on from H Metrics? Okay. So one thing I can tell you, Stephen, is that every year Paces kind of goes over their episode definitions. This year they did a very extensive revisement on their orthopedic episodes, and in doing so, which again, those business rules haven't come out yet, so you actually probably don't have a copy of those particular business rules. But bottom line being is that what we have found is that there is duplicative attribution here for the same episodes, same patients, etc. And so in that aspect, that is why we have put in place the mutually exclusive episode rules here.
Yeah,
Again,
I mean, if we
go ahead.
can get the documentation from H Metrics, spend a good bit of time on those business rules and a
crosswalk. Yes. Yeah.
So,
agreed. Understood.
all right. Thank you.
Yep. Dr. Mitchell, what about the current year if we are participating in both ED and PACES episodes? For the current year, this is a non-issue. Like at this point, again, you have to understand the more episodes we add, the more that we are seeing this duplication. There has always been a bit of duplication before. It just hasn't been to the extent that we have seen and that we are going to see in program year 6, which is why we have added that mutually exclusive episode rule. Rupa, if we do, oh, Jean answered the question. Perfect. Okay. Any other questions before we move on? I don't want to minimize this. I realize that this is a concern for many of you. So if there's anything else you want to talk through, or we'll also have Q&A session after we've gone through the slides completely too. So anything else? Okay, we can move on to the next slide then. And then these next few slides basically just go over all of the different episodes that we are offering currently for program year 6. As stated before, you can continue going through. There's about 144 episodes in total. Okay, next slide. Quality measures. So I kept these slides in here because these same quality measures are also going to roll over into program year 6. Next slide. As you can see, I've gone through all of these quality measures. I've broken them down into fairly easy to understand bullets. We've also linked the CMS definition here. That's the underline in green, all the words in the green. And for the hospital-wide readmission, there are no claims that you need to drop for this particular measure. The only thing that we ask is that you do your due diligence and you follow your patients and try to keep them out of the hospital, try to keep them from being readmitted. Go ahead, next slide. The rest of them, the rest of the measures, we do have, next slide. We do, as you can see, I've broken out submission codes for each of those. And again, you do get credit if any other provider has dropped these codes for your particular patient during the year. But just to make absolutely certain, especially if you're doing the work, drop the code for it. Next slide. I know everybody's reviewing medications with their patients. Drop the codes for it. Next slide. Next slide. Okay. Again, same thing for BMI. So with your advanced care plan and your BMI, even just having a simple conversation about it, and as far as BMI, like documenting in the chart BMI, drop your codes. It's that simple. Okay, next slide. Data release schedule. Next slide. All right. The PY4 reconciliation data. So we want to acknowledge the delay in the release of these PY4 reconciliation file. Understand that many of you have been waiting for this information, and the delay has kind of created some uncertainty and frustration. CMS is basically making some changes to their CCLF file format for the new AHEAD program. And in that, sometimes the information that comes across is incomplete or is in a form that we have to basically go back and revalidate and redo a lot of the data, and that does take time. In the data release situation, there was missing information, and so therefore that is why, and it took this long for us to get the correct information from CMS. But I promise you, first of all, we appreciate your patience with all of this. But I promise you what is in the portal right now, and as of July 13th, this is final, and it is the official file for program year 4. Next slide. Okay, so here would be the particular release dates for the regular monthly update in the portal for your data. So episodes ending in February will be published the second cycle, July 2026. Now, again, I want to emphasize, especially nowadays, the dates are tentative because of the different changes that are happening and the way we are receiving the files from CMS. Sometimes we may need to, there's either missing information or we may need to revalidate a lot of the data. So that will sometimes push it to a delay. I just want to preface this because I want you all to understand that even though we say July, second cycle of July, the EQIP data will be released, it could be the following week. It could be another week after, depending upon what happens. We will get the data in the portal as quickly and as seamlessly as we possibly can. I also will let you know that when we know there's going to be a delay, you will receive an email from us letting you know. We'll communicate to you as soon as possible that there is a delay coming. All right. Any questions so far on anything that I have talked through? Victoria.
Good morning. I just had a quick question about the new quality measure because I saw that on the PY5 composite quality score report that Chris was doing an evaluation for that metric before it was added to that report. Do you think that that information would be available for the July 2026 data release? Because I think that the evaluation by Chris was done in early July. So earlier this month, but I didn't know if you had completed it yet.
That I'm not 1,000% sure that it's completed yet,
Okay.
Victoria. So I would say look for it, but I can't promise you that it's going to be in there, but should be in by August.
Okay. Thank you so much.
You're welcome. Anything else? Okay, is Jessica on?
Hi, I am.
Awesome. Okay, I'm going to turn it over now to Jessica Heslop to talk to you all about an amazing opportunity with the Rural Health Grant that we have. Next slide, please.
Kim, do you mind actually if I take over? I might have updated. Sorry, didn't mean to catch you off guard.
No worries, go for it.
No problem. Let me see if I can share the right screen, and I will do that. Okay, hopefully you guys can see my presentation.
Yes, we can.
And now how do I click through it? Okay, so yeah, this hopefully won't take too much time, but I did want to share an opportunity that's being offered, obviously statewide, related to the statewide grant for rural health and the different types of pillars that we are trying, where really the state is trying to support the communities in those areas. Just to start, I'm Jessica Heslop. I'm the Director of Engagement Strategy and Outreach at CRISP. We have a wonderful team, both on the outreach side and new people that have been added for rural health. I believe my colleague Jess Deagle is on the line. She's our lead account manager specifically for the rural area. We also have a technical lead, Cesar Pancheo, and then my colleague Rachel wasn't available today, but she's our senior project manager, really owning this connectivity program. But all of us are there. I also will give a one email. You don't need to remember our names or anything like that, as a way to kind of get all of us if there's any questions. So I think everyone's familiar with CRISP background, but I just wanted to talk a little bit about the different data that we get and data exchange, as it obviously is a foundation to why we are pushing and have this connectivity program as an offering. So as you guys are aware, obviously data exchanges, our hope is that it really amplifies care coordination and really make sure that information with a patient just doesn't stay with them, but it really follows them across different settings, different systems, different EMRs, et cetera. So really that is the hope of looking at the data availability, data readiness, data timeliness, all of these things. When we think about data exchange, you guys are probably actually most familiar with this payers and state agencies. That's probably the most important information that goes into this specific program. So for example, claims, we also get public health data. But the other three areas are obviously of vital importance and play core to the offerings that we have. So we get primarily from hospitals and health systems, real-time data. That's our ADT data, imaging data, discharge summaries, things like that. We also are closely connected with LabCorp and Quest for outpatient labs. So we're getting lab results. If there's independent labs and in-house labs, we also have connections of those. And then this red CRISP participants. So that's the big one. That's you all, basically. And that's where information that aligns what patients you are seeing, we can match that up. with information we have in our system. So again, there's a variety of information that's being sent in that area, but I would say the connectivity program is primarily focused on amping up that CRISP participant data in the rural health areas, again, with the hope that there's more visibility and connection for communities that are, more dispersed. Just a little bit of where we are sort of today. And again, this is the snapshot of some numbers. You can kind of see the total number of clinical documents that are processed on a weekly basis, the number of encounter notifications. So if your patient is in the hospital, if your patient's readmitted, things like that. We also have the abilities to send messaging directly into EMR. So like in an in-basket type of messaging, we're sending many of those. As well as the manual searches. You're just trying to look for basic information, where to start. We have a lot of that there. And that's really represented by, nearly 50,000 active organizations, 50,000 active users across 21 active organizations. But we know that only scratches the surface, and we also have stronger penetration in more urban areas and even in certain specialties. For example, we know behavioral health, the connection is there, might not be as strong as we see in primary care. So variety there, but there's a lot of information that's currently there. So the why. What is this rural health connectivity program? Why are we doing it? Again, some background here. As part of the state funding, there was over 165 million awarded to the state this year across a couple different initiatives. But interoperability is one of the primary initiatives that the state is looking to push. CRISP is partnering with the state and offering what we're calling the Rural Health Connectivity Program. So basically, what is that? It is a program which offers funding to eligible practices or providers for connecting with CRISP in one of the 3 milestones. And I'll go into details of what those milestones are. I think the big thing we want to emphasize is you don't have to do them in numerical order. You can choose to do just milestone 3, just milestone 2. You can do 1, 2, and 3. And also we know that people's starting points may be different. So some people, it might not make sense to do all 3. Some people actually may have already been achieving milestone 1 and they're looking to add on. But the goal of this is to increase, again, that specifically that real-time clinical data that the rural health communities will hopefully be able to benefit from. I will go over what that funding, the eligibility is, the funding numbers are, but do want to emphasize that the funding is available on a first come, first served basis. The sort of intake form, we hate to say application, because it's really more of eligibility criteria, less so than competing or any type of thing like that. But it is a first come, first served basis. It opened just about 2 weeks ago, maybe closer to 2.5 weeks ago at this point. So let me go over what those 3 milestones are. I'll go over eligibility and next steps if you're interested. So the first milestone 1, is connecting your admission, discharge, and transfer data. So what we refer to as ADT data. And these are messages essentially when a patient is registered, admitted, moved to a different location. I think we primarily think of these as hospital related, but really there's ADT messages obviously across any setting, or really key demographic information has been updated. We can get that to other members of that patient's care team in a timely fashion, rather than waiting or having the patient have to say, oh, I already thought I told you this, or things like that. The purpose here is that ADT messages really utilizes the HIE and CRISP to help your organization stay connected in a very timely fashion. I think that's the big thing here. Again, this information does exist, but it probably would be many months until it gets updated. ADT data is very different in that way. It also really is the mechanism to empower send capabilities. When I say send, it's a little bit of a CRISP terminology, but it stands for CRISP Encounter Notification Delivery System. So what that means is the alerts that can be set up about your patients. Again, has someone been readmitted? Is there an overdose? Is there a preventative service that was offered, like mammography or colonoscopy? Certain alerts are global, open to everyone. Other alerts can be set up, but help your team either prioritize or just be in the know of certain important information as it relates to your patients. ADTs really are such a crucial pinpoint in order to make those notifications really meaningful. So again, really robust in the hospital setting, but obviously we know that isn't where all care is being offered. And in order, especially in these rural communities, in order for patients to, practices to be aware of when their patients may have such an event, the ADT can be super vital there. That's milestone 1 when we talk about it. Milestone 2 is it's similar fashion, but maybe it's a different format, basically, and different types of information that's offered, but it's still in that real-time clinical data field. And it's called CCDs, or continuity of care documentation. And basically it is a standardized structured snapshot of a patient's care. It includes more information typically than ADT. So it's sort of a level down, like medication, allergies, lab results, procedures, in a consolidated format, and a standard format, which allows it to be seen in other places within CRISP. And again, you don't have to go searching for it, because we know everyone uses slightly different formats. It even allows for certain things like lab results to be reviewed on a timeline type of fashion, even when that's being occurred at multiple different settings. So again, kind of what the second bullet here is sort of saying is it does give that fuller picture than ADTs would alone. Both are important. They both give great things. Together, it really does open a ton of opportunity and window into a patient's care. And really, again, the core is what it is looking at, is that care coordination and connecting organizations and providers for information, and hopefully supporting transitions of care across different settings. Milestone 2. So milestone 1 and 2 are information that practices would be sending to CRISP to enable more tools, to enable connectivity. Milestone 3 is slightly different. It is our In Context app. So I'm actually going to go one more slide and come back. Just for some background here, all of the CRISP clinical information is available to whomever is connected. And really right now there's 2 access points. Many of you are probably familiar with our portal-based application. So you go to www.portal.crisphealth.org. You enter in your name and password and you get into Portal. You can click on the report style and you get to your EQIP information, but also you can use the patient search function and get to your patient information that way. Again, all that information is there. In Contacts, the embedded app opens that information directly into your EHR. So same information, different access points. So what milestone 3 does is we provide funding to assist in bringing CRISP directly into your EHR's workflow. So instead of having to do that patient search, and again, there's slightly differences for each of the EMRs, but for the most part, if you are actively in a patient's chart, there's a button, there's a link, again, it looks slightly different, that allows you to directly see the clinical information that is related to that patient that you're already viewing. So reducing time, reducing workflow, additional steps. Honestly, what we hope is that it increases the utility in general of the CRISP information. We know just human nature, having to log out, remember another password, that's tough to do sometimes. So the more we can fit information into your workflow, we know the better. I listed a couple here, basically, of platforms. There's a wide variety of platforms that we are actively live with, and this is only just such a short amount. But that's certainly something we can explore if you don't see your EMR down there. That isn't to say that we can't support that. That is milestone 3. So again, remembering that this is a pick and choose menu, 1, 2, or 3, or all of the above, what makes sense to you guys, and what would be most beneficial would be, hopefully provide some interest there. So let's talk about who qualifies. So it is a rural health connectivity program. So the biggest thing here is that it only qualifies for HIPAA covered providers located in the Maryland designated rural health counties. But there's 18 total. You can kind of see them listed below here and on the map. There is a small exception if the practice is technically not in a rural county, but maybe on a border, and a lot of their patients are coming from the rural counties. We're certainly open to exploring that and seeing if eligibility could be met that way. So kind of talked about this here. So you have to be HIPAA covered. You have to be in the rural areas. Again, there are technical capabilities. You do not need to know that going into it. We can help you all determine that. But I think the big thing is that it is a partnership. Many of these, it's obviously an interface, it's an integration, inbound or outbound, depending on which milestone you choose. So it's really important that we have a reasonable access and participation with technical folks, either directly in your team or helping liaison between your EHR vendor to ensure we can make these go live successful. The program requirements, program design. So as I mentioned, there are 3 milestones to pick from, but independent of what you choose, there are prerequisite requirements for everyone. So for anyone in EQIP, I think most of these probably have already been met, but basic onboarding requirements to CRISP are required. So that includes things like signing your participation agreement, ensuring that, we have a notice of privacy practice attestation, sort of the paperwork associated with it. That is important that we have established before we go live with this or enter you guys into the program. A executed memorandum of understanding is required as part of that prerequisite. And there is some seed funding that as soon as those are done, before any integration or technical stuff starts, we provide $2,000 in funding just to say, hey, we understand we're all on the same page, we're entering into this, and we're excited essentially to go forward. So those prerequisite requirements are done. If you've met all of them and it's just simply signing the MOU, that's how you meet those prerequisite requirements. But we know the starting point for each practice may be different. So here's the payment structure and the program design. I mentioned those 3 different milestones. So for ADTs and CCDs, it is a flat payment of $7,500 upon completion or that feed going live. We are using an attestation to essentially say, yep, this has been done. You guys agree, we agree. And for the in context, it is an $8,000 flat fee. So all of those, if you choose that milestone, that is the payment. There is some scalability based off of size that we wanted to incorporate. So in addition to those flat payments for the milestone achievement, with your last payment, so potentially people could be getting multiple payments, but with your last payment, practices will receive $500 per a full-time FTE. That's a physician, a nurse practitioner, or a physician assistant. Again, that'll be included with the final payment up to $15,000. So if you're a large practice doing all 3 things, you're seeing a total maximum payment to an organization of $40,000. We would help with all of this. So don't feel like you need to know exactly all of this right going into it, but hopefully this gauges some interest. What is this process? If this is of interest, what does this sound like? How do I know information? How do I find out what I'm eligible for? All of that stuff. So the first thing that we have, and I'm happy to drop it in the chat, is it's an intake form, and that really kicks us off. What that does, it allows our team to really do a deep dive on your account. What's your current status from a contracting standpoint, from a connection standpoint? Let's look at your FTEs. Let's look at the locations. And essentially, we would start with a kickoff meeting to say, yep, we're all in agreement. Any questions? Let's line out the next steps when it comes to either a technical aspect or a contracting aspect. So that intake form really, we're happy to have informational calls with people, but that's really sort of the starting point of like, hey, I really want to know my eligibility. We are pointing people in that direction. Once we do that, essentially, we're going to look at that first prerequisite, make sure that MOU is signed, and then go through the different milestones. As soon as that attestation is signed, that payment would be delivered with that. And again, at that last payment, whichever it may be, we would give that FTE provider payment as well. One of the big things, and apologize I didn't mention, in that attestation, really the big thing, not only obviously you're going live with it, but there is a commitment to maintain that feed for 1 year. So if you go live, let's say, I don't know, November 1st of this year, it would be in that MOU and in that attestation commitment to maintain that feed until November 1st of 2027. That is the commitment for the payment as well. Okay, I talked a lot. Essentially, there's an email address to reach us all. There's information, again, I'm happy to drop it in the chat. We have a flyer. There's plenty, like I said, we're happy to talk to whomever if there's of interest, but that is my spiel, and I guess I'll open to questions
So,
if
Jessica,
I can
there's
find
one
my
question in the chat,
chat.
and essentially it's asking, what if we've already done one of the milestones? So obviously you could do the others, but go ahead and you can fill in or answer a little more.
Yeah, exactly. So if you've already completed one of the milestones, you obviously wouldn't be eligible for that, but that doesn't exclude you from being eligible for any of the other milestones. And that's sort of where we know people's starting points they're different. Again, some people are nowhere connected into our anywhere within the CRISP system. We have some folks that are actually already sending ADTs, CCDs, but in context has always sort of been, for whatever reason, a barrier. And we've had some applicants that this is a perfect opportunity for them to sort of add that on and have the CRISP inflow in-app workflow rather than what they're doing in current state. So.
And quickly, Jessica, if it's okay, maybe Jessica Deagle, who's on, we can introduce her as well. Jessica is working with MedKai and CRISP together, and she is willing to answer any questions or help with anything. Just say hi, Jessica.
Good morning. Hi, everyone.
So you can reach out to either of the Jessicas and they can help you with this program. So if you just ask for Jessica, you'll be in good shape. And I have one ask, if those of you who are with hospitals in those 18 jurisdictions, if you could share the intake form and some information with the medical staff, because while we know that a lot of the hospitals have probably completed all 3 milestones, you have other practitioners who have privileges or are connected with the hospital that might not, and it could be very helpful to you. So we'll make a point of emailing out Olivia or Kim or one of us will email out some information on the program. And if you could just share it widely, the state is going to be making decisions about what gets funded for HR1 rural health funding for next year in the fall. So we would really like to efficiently use this money and get it out and show some value so we can make an argument to add more revenue so more practices can participate. So if you could just please share this, we would greatly appreciate it.
Jean, thank you. That's a really good point. We have gotten some recommendations from hospitals saying, hey, this is the practice that always asks me to fax something, all the time. This is the perfect opportunity if they're in these counties for us to connect. 2 things I totally forgot. There is a webinar, like an informational webinar on Tuesday. So this plus a little bit, essentially, we give you a preview of it. But it's a good opportunity if you want to share that with anyone. The registration link looks like did not go through, but I will add that in the chat again. And then, as Jean mentioned, we hope that this is successful and we have a version of this connectivity program for all 5 years of the rural health program. It may not look exactly like this. There might be new quality or new milestones that could be data quality focused, who knows, but completely want to echo Jean's. The more buy-in that we can show and say, hey, this is a value, we could really expand this. And hopefully, like I said, the whole point is to make this more readily accessible for our end users and more meaningful data for you all, even if you're not in the rural areas. If those are the areas that you are finding the hardest to gather information from those patients, this is hopefully will help with that. So.
Any other questions from anybody here for the rural health grant? Okay. Jessica and team, both Jessicas, thank you so much for your time. We appreciate it. And excuse me, as Jean said, Olivia and I will be sending out emails to everyone so that you can start the processes there. All right. Okay. Now we're going to open it up to Q&A. If anyone has any other questions, concerns, feedback, anything that, you want to get off your chest for the moment?
I'm not sure. I think we answered it, but just in case someone asked if the issue with the crosswalk, if they're currently participating episodes in the current year, that it does not, any of the changes do not affect the current year. It's for
Correct.
the next performance year. I think we answered that, but I just wanted to reiterate it because it was important. And I saw two questions like that. And then I see another question here. Can an entity remove a provider from the entity after the enrollment deadline closes if it's before the CPAs go out?
Yes, you can remove providers. You cannot add providers, but you can remove providers.
You cannot remove providers once the performance year has begun.
Correct. Correct. But you can
Victoria,
remove, right.
Victoria, you had a question?
Hello, can you hear me?
Yes.
Okay. I had one question, just like going back to some of the changes that have happened with the mutually exclusive episodes. Is the episode attribution across the board expected to change? Like if you have the exact same MPIs that are available in the portal from PY5 going into PY6 enrollment, is the episode attribution in terms of whether that entity would still be eligible for the episodes they're currently participating in PY5? Is it expected to change?
It
Because
can change.
oh, can
It can
change. Okay.
change. Yeah.
Okay.
Yeah. It can change.
Okay.
Correct.
Thank you.
You're welcome. And again, I get everyone's concern, and we will put together a crosswalk for everyone so that you can get a better understanding of exactly what the mutually exclusive episodes are, as well as the reasons behind it and all the details. Let's see, if patient panels are required for 2027, will we be able to see which patients are captured in the denominator for the quality measures? So, Rupa, we are working on putting this together. It is not fully realized as of yet, but that is the goal. It is the end goal, yes. There are lots of changes coming, so and additions, and hopefully will be make things a little easier for everyone. Any other questions?
All right. Well, I guess we're done, Kim.
Yep, let's go on to I have a couple of more slides real quick. I think they're just resources. So yep, resources. So I've listed out CRISP website, curriculum, playbooks. We have the new EQIP PY6 playbook. The PY6 policy documentation and specifications and methodologies are almost completely finished. As soon as they are done, we will upload them to the website. And feel free to peruse the website and download that information as well. There are some changes in those documents as well. All right, I think that's it. Next slide. Yep. Thank you all so much. Again, if you have any questions, any concerns, feedback, otherwise, please reach out to the EQIP inbox. And we greatly appreciate your partnership and participation in the EQIP program. Thanks so much.